This conference will now be recorded.
Thank you. All right, welcome everyone to the AnCan High Risk Recurrent and Advanced Prostate Cancer video chat session for Monday, September 18. I'm Len Sierra. I'll be moderating today with a little help from my moderator friends. And before we start, we'll thank and acknowledge our sponsors, Bayer, Pfizer, Myovant, Janssen, Myriad, Telix, and Foundation Medicine. Let's see. I'm calling on people as they arrived. So our first man to take the floor will be Joel Blanchette. You're up, Joel.
Thank you, Len. If you remember, Dr. E in Houston wanted me to, after being negative for prostate cancer on 3 MRIs she gave me and the Illucix scan and seeing a neurologist, and he couldn't see any cancer in me, at least on scans. Of course, we all know we have microscopic cancer. Um, um, she wanted my radiation oncologist to radiate L4 and T6 and T9. I did go see him um, 3-4 days ago, and he's going to give me 2 more MRIs because the ones that Dr. E gave me were abdomen, chest, and pelvic, and he's going to give me 2 a thoracic MRI and a lumbar MRI because he's got a plan for, he's planning SBRT for me. And he's planning 5 sessions of fractionated SBRT. He says that 3 lesions that the Dr. E is talking about, he can radiate all at once in all 5 sessions, so I don't have to do one spot at a time. He was very happy that I had a recent colonoscopy and endoscopy because those were clean. And he says if your mediastinum lymph nodes were neuroendocrine cancer, they don't usually, neuroendocrine doesn't usually show up there. That usually shows up in the intestines. And since you got a clean colonoscopy, I'm not too worried about that at all. In addition, I'm talking to a medical oncologist at the Veterans Administration tomorrow. He's the guy that approved darolutamide for me, paid for by the VA, and he's also the guy who approved my FDG PET scan, which showed a cyst on my liver and a mediastinum lymph nodes that were 4.2 SUV. My radiation oncologist said that's pretty normal as far as the mediastinum lymph nodes. He says everybody sometimes gets that because of the environment you live in, air pollution, and so on. And so he wasn't concerned about cancer there at all, even though they were positive on the FDG. So he says, in the meantime, a couple of weeks ago, or 3 weeks ago, the VA, after finding out the results of my FDG, sent me a letter that says we want to do a ultrasound on your liver cyst. And Dr. E agreed, and so I'll be doing that in the near future. And he says, why don't you ask that medical oncologist to also take an ultrasound of your mediastinum lymph nodes? So I said, okay, I'll ask him. So I'm have a phone interview with him tomorrow. So basically, that's my latest update.
So Joel, I'm curious, have you ever asked your radiation oncologist or your medical oncologist how much radiation is too much, and are they at all concerned about your bone marrow? Are your blood cells values good? Your red blood cells, your white blood cells, is that all
Yeah,
good?
blood cells are okay, but of course I've been worried about that because I've gotten like good God, I lost over a dozen scans, whether PSMAs or SB, um, CTs, bone scans, and MRIs over the past 2-3 years. So that's always a worry. About. Plus, I have 5 PSAs behind me now, including the last one was a Illuccix instead of DCFPYL. So I'm concerned about that, but no, they have never raised a concern about it.
Okay. Yeah, the MRIs, of course, you don't need to worry. There's no radiation there, but all the other stuff
Well, what
you
about
do.
the contrast they inject you with? Is that not radioactive, or maybe it's not?
I don't think so. I don't know. Does
Okay.
anybody have an answer to that?
No, I don't think so
Oh,
either.
it's
No.
not.
Okay.
Okay.
All right. So yeah, I am concerned about it, but I'll ask the question tomorrow with this medical oncologist and see what he says.
So
Yeah.
the
Go ahead,
contrast
Rick.
is not radioactive, but it's very controversial. I shouldn't say very. It's controversial with the active surveillance, the early active surveillance guys. And actually, Howard Walensky has done a whole long, lengthy magazine article about it. And if I can find it, remind me, what's the name of the contrast again?
Gadolinium?
Yeah,
Oh yeah.
that's
I
it,
think.
gadolinium. I'll try and post it in the chat window. The bottom line is, it's probably fine, but especially for us guys who have had so much radiation and other stuff anyway. But for these guys who are sort of virgins to treatment, they don't even want the gadolinium in them. So let me see what I can find. Is it Sean Collins that you're seeing, Joel?
If you mean radiation oncologist, no, it's a Dr. Eblin who radiated before and was successful in radiating my left iliac bone and my right occipital condyle bone.
Okay.
And Dr. E liked him because he succeeded. So I
Okay.
asked,
Yeah, the gadolinium contrast revolves around deposits in the brain or something, if I remember right. And so there is a fair bit of controversy about it.
Yep, that's true. Anybody have questions or comments for Joel?
I think one of the major issues with gadolinium, like iodine and all those other contrasts, is the effect on the kidneys. And if you have marginal kidneys, that increases the risk to some degree, and that's when they stay away from that stuff. Accumulating in the brain, I mean, it's been talked about. I've heard about it, but it's not a major conversation among people who radiologists who use gadolinium. At least that's my experience. I don't know, maybe Jeff has some ideas about that.
Jeff,
Or
you want
John.
to opine there, or you'll pass?
Put on your sound, Jeff. Your sound is off. You're muted.
So I think it only crosses the blood-brain barrier when there's a tumor, when there's something that interrupts the intactness of the blood-brain barrier. But without a tumor, it should not cross the blood-brain barrier.
So I'm posting Howard's article. Hopefully the link works, and you can all become experts on gadolinium. It was in a magazine called Chicago Med, I think in 2019. Everyone, there you go. Enjoy.
Thank
And
you,
for
Rick.
those of you who don't know who Howard Walensky is, he's on our advisory board. He is a very active prostate cancer advocate for the early low risk active surveillance, gents.
and he's kind of a stringer or whatever you would call it for, what is it, Medical News Today or one of those.
MedPage Today. He writes in a number of the MedPage Today is one, and he writes in a couple of others as well.
Okay. So we have, oh, somebody wanted to say something?
I just wanted to say that I just tried that link and it didn't work for me.
Okay. I've got another one. So let me see if the other one works.
It got me to, oh no, got me to Zinni.
Yeah. I don't know no, it doesn't look like the other one works either. So, all right, sorry about that. I'll send Howard a text and ask him for a link to it.
All right, let us move on to Mark Baldridge. Go ahead, Mark.
Hi, thank you. So I recently had a Pylarify scan, and it showed the pathology report showed two lesions. One was like a definite metastases; it lit up, but the second one, I'll just briefly read. It says a tiny sclerotic lesion in the posterior right fifth rib with mild focally increased uptake that is more intense than expected for size. PET image 139, CT image 156. And I've heard there's controversy about about the rib, and false positives. But my question is, like, I don't want to overly radiate, and yet if it is a metastases, I don't want to like just let it go. So my radiation oncologist said she talked to the pathologist, and
No, not pathologist, the radiologist.
oh, sorry, radiologist. Well, anyway, does the group have any suggestions on, like, if I'm kind of on the fence about this, which way to turn? How do I know how to make the right decision?
Because the description on the report was that it's mildly focally increased uptake, where the other one was like intensely uptake, high SUV uptake. There was a number given. This one, we didn't have a number associated for that SUV uptake. It just described as mildly increased uptake. So
That's why the professional flower for radiologists is the hedge, because they can talk like that. It's a this is maybe a false positive, and it may not be. It just looked wrong to the radiologist that read it. It looked too bright to be an old scar, which is what sclerosis is. But it didn't look bright enough to measure it or anything. I expect that something like that I don't think they'll feel, I don't know, but I don't think they'll feel there's enough evidence to radiate something like that. I think they'll probably ask to rescan you in 6 months and see if it's changed any. I don't know.
okay. And I guess, the radiation oncologist that he saw, she's only had 3 years experience, beyond her education. So, it's not like she's been in the field for 15 years. She's relying on the expertise of the radiologist to interpret it. So,
Well, nobody's had much more than 3 years experience with PET scans, PSMA PET scans.
okay.
Mark,
yeah.
do you have any pain or discomfort from these bone meds?
No, I haven't noticed anything.
I mean, that opens up a discussion, like when to go after things. Do you go after when it's noticed in a scan, or when it's causing discomfort, or whatever? I mean, it's an interesting discussion.
So I am on my GU medical oncologist wants me put me on 6 months of abiraterone and 6 months of
Well,
traditional ADT Eligard, but
she didn't really specify the amount
oh
yet.
well,
She just started you on
she
it.
started me on those. So I guess there's a thought that, like, at the very least on the rib, it may go into dormancy, right? I mean, maybe not eradicate whatever it is, but maybe it would just go into dormancy. I guess that's kind of like pushing the can down the road, maybe.
Well, Mark, at the bottom of the report, there's usually a section called, I think they called it impressions.
Hmm.
So in that
Okay.
section, did they elaborate any more on the rib?
Let's see. My wife's looking at it with me now. Impressions.
Um, okay, at the very beginning,
Oh,
impression. All she wrote down was likely two small PSMA expressing bone metastases.
So she's calling it a metastasis.
That's what this the experienced radiologist is. Apparently she's the most experienced at this center for interpreting the PSMA PET scan.
she's a Fred Hutch.
I guess you could always get a second opinion.
Yeah,
Hmm.
yeah, and they've got some good people at Fred Hutch who have read a lot of PSMA scans.
Hmm.
So if she hasn't read
Oh,
enough PSMA scans and she doesn't have the experience, then maybe find out who heads the radionuclide service, and they could look at it,
well,
or ask her, tell her you want somebody who's read a lot of these
well,
to read it.
the rate, the radiation.
Hold on a second. Hold on a second. Hold your thought. Joe Gallo, is your man still at Hutch? Your and Andre, whatever his name is.
That's it. No, the, uh, the radionuclide guy that I have at Fox Chase. I'll have to come up with his name again. I can give you
No,
that.
but what about the fellow who was in Seattle at Hutch? What was his name? Westfeld?
Um,
Westfall?
Westfall.
Westfall. Is he still there at
As
Hutch?
far as I know.
And what's his name?
Yeah. If you hadn't asked me, I could have told you right off the top. Uh,
I think it's Andreas Westfall.
Okay.
Andreas is over in Antonio. There you go, Antonio Westfall.
Antonio Westfall.
Yeah,
And he's
Andreas is at Fox Chase.
okay. He's a really good guy. He
Hmm.
knows Captain Joe
Yep.
well. And at one point, he used to offer to do second. Isn't this the guy who used to offer to do second opinions for us as long as we made a donation to Hutch?
Well, he was doing them for no charge, and his boss told him to please ask for a donation. So I think he still does it. I think he still does them.
Hmm.
Antonio Westphalen, he did a webinar for us about 2 years ago.
Yeah.
Okay. Thank you. Thank you. Maybe I can contact him then and
He,
ask for that second opinion.
he's very open to discussion as well.
Thank you. What a great tip.
Let me see if I've got. I put his name in. He's a really nice guy. He knows AnCan. He likes us.
Hmm.
And if he doesn't have the experience with the PSMA scans, he's the sort of guy who's going to tell you this is who should read it for you.
Yep.
Okay.
Okay.
Okay. Now, what were you thinking of?
Well, it's just that the radiation oncologist said that the person that read the scan, that she was like the expert to read it, of the people available to read it. So, that's why she didn't question the results, because she said, well, you're having the person who's most experienced with the PSMA PET scans, read your scan. So we couldn't say anything to that.
Yeah.
No, but
Yeah.
I mean, it was somebody by the name of was it Chin, a female gal?
oh
Anyway,
yeah, she's very nice. We like her too, with a D. Her first name starts with a D.
Chin. I think her
Uh,
last name was Chin, maybe
yes.
Chin.
Yeah, no,
Yep.
she's good. She is good. She's very good. If that's who read it, she is good. She's the radionuclide lady there. We tried to
Okay.
get her to do
Okay.
second opinions for us, but they were too busy. Um,
Okay. Well,
uh,
It looks
yeah,
to me like Dr. Westphalen is still affiliated with Fred Hutchinson and has
right.
fantastic credentials for this sort of thing.
He does,
well,
but he's not. She's the radionuclide lady. I'll tell you her
Mm.
name in a second. Because I remember, because I definitely saved it. No, of course I can't find it when I need it. Oh, Delphine Chen.
yes,
Okay.
yes.
Delphine Chen. Yeah,
And it
no,
was
we had a correspondence with her. Why don't you have you talked to her directly?
no,
Not yet.
in fact, her name wasn't even on the report, which is odd.
Okay,
I
so
mean,
here's another suggestion for you. Talk to
yeah.
Delphine Chen. I'll send you her email address because we had correspondence with her. Tell her you're an AnCan person because she talked to us
Okay.
for
Okay.
a while, and
Yeah.
ask her if you can talk to her because you're really not sure what to do.
Okay.
Right. And Rick,
Okay?
the reason why I bring this up to Mark about it, because I read a lot of articles that said if you have a single solitary rib lesion, a lot of times they're benign. And so, anyway,
Yeah.
Yeah, to
Well,
put a number on it, I heard that 25% of rib Polarify scans with showing some uptake in the ribs are false. 25%. That's pretty high.
wow.
Yeah.
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 Okay.
Okay.
Well,
Okay. Well, thank you. I'll let you go on to the next person, but thank you for that tip, Rick.
Okay,
I'll
and
contact her.
I have her I do
oh,
have her email. I'll send it to you directly.
thank you
Thank
so
you.
And
much.
she seemed very, very nice, but we couldn't get together on what we
Okay.
needed her to do, which was we were hoping she'd be a source of second opinions for us. So we were willing to recommend her, Delphine Chen, for second opinions.
Okay.
Okay.
Would it be out of place for us to ask for a second opinion from that other Antonio Westphalen? Would that,
No, I mean, you could even say, would it be okay if we asked Dr. Westphalen? I mean, here's the thing. I think Westphalen's going to have a much better sense of prostate cancer lesions because he does a lot of prostate cancer work. Dr. Chen is a radionuclide doc. So she's
okay,
just coming. And this is really what we're going to be talking about when we get to do our webinar with Dr. Kuo and Dr. Sartor, because this intersection of technical and clinical, it really hasn't been resolved with radionuclide medicine yet, because the radionuclide docs, they're very smart, but they don't have the clinical expertise. And sometimes on the other side, the medical oncologists don't know enough about the radionuclide. Now, Sartor is an exception because he knows a lot on both sides. He's probably one of the best he and Morris are probably amongst the best educated docs in terms of radionuclide medicine and clinical practice. But this is a really good example of where it's important. But I think you'll find Dr. Chen is very nice, and I think you'll be able to say, could we also ask Dr. Westphalen?
yeah.
Because
Okay.
you can say because he's an AnCan fan, and I
Oh,
think
okay, okay,
Okay.
okay,
okay, okay.
Thank
and then
you.
make him a little donation at the end, and they'll be very happy with you. So
That's
will
fine.
we.
We'd be
We'd be happy.
Okay.
glad.
Goodbye.
Okay.
Thank you.
Anybody know where we are with the AI reading of scans?
Well, you
No?
know, Pylarify, Lantheus was kind of furthest along because they developed an AI package when they launched Pylarify. But the thing is that the doctors have to pay for it, so it's not free. So it doesn't. You have to buy that package from Lantheus if you want it. And what we were learning was that originally, and there were doctors like Dr. Efstathiou who were saying this, that the AI wasn't great, and that there were too many false positives with the AI package. But I don't know whether they fed stuff back in and whether they're more up to date. But that's the limit of my knowledge on AI. Telix is developing something. I know that for sure. I don't know what Blue Earth is doing. I haven't talked to them about it.
All right. Thank you, Rick. Dr. Jack, you're up.
As you may recall, I've had SBRT. Oh, I'm getting an echo, so I hope you can hear me. I signed out, I signed back in, so I had, you hear the echo because I could hear myself speak.
Yeah, if you can hear yourself speak, Jack, turn your volume down a little bit. That might take care of it.
Okay, that's better. I'm seeing my radiation oncologist after having had SBRT for my rib lesion that I chose to. It was a shared decision. You're struggling to make that because he wasn't too sure. I had it read by Sloan Kettering, I had it read by California, I had it read by here in Miami, and everybody was a little, they didn't know for sure, absolutely. But I erred on the side of caution, and I had, you can go ahead and do the SBRT on that rib in addition to the vertebrae and 3 subcoronal lymph nodes in my lung. So tomorrow I'll see the radiation oncologist for the first time in 4 months. And I'm asking if the group can help me sort of navigate how to approach my radiation oncologist. I want to make sure I ask the right questions. And the main thing that keeps coming up in my mind, the first question is, how do I know if the SBRT worked? And how do you follow it when your PSA is dropped to 0? And I know we can't get scanned. I know it's too early for an FDG scan. And other than scanning and following the PSA, is there any way of knowing how efficacious the SBRT was? And what questions would you ask other than what I'm asking, or has anybody asked that question to their radiation oncologist and gotten an answer that was satisfying? Can you hear me?
Sounds to me that's sort of the same question that Mark just had, isn't it?
Is it?
Well, I mean, Len, go ahead.
Hello?
You with us, Len?
Len, you're muted.
Sorry about that. So I wasn't clear, Jack, on what your concern was. Was your concern that the rib lesions might be false positives, or was your concern that you're getting too much radiation?
No.
Go ahead.
No. My question was, I'll ask it again. How do you distinguish between, how do you determine how effective the SBRT was over time? I haven't seen him in 4 months. Is there any way he can tell me whether or not the SBRT was effective or not? And how will he determine that?
I suppose,
Well,
Jack, the way to do it would be to go back to whatever type of scan it was that
That's right.
identified the lesions
Yeah.
and use that exact same type of scan again and
Who's
compare
talking to
the
me?
two.
John?
It's John. Hi, Jack. Hi, Jack.
Hi, John.
So
John, my
am I
PSA is 0.
oversimplifying?
My
Yeah,
PSA is 0.
yeah. So you mean you
Yeah,
might
but
have sort of blocked out the brightness of the lesion by ADT, and therefore there's no way to know whether it's worked or not?
And the PSA alone is not going to determine whether or not it works. Is that
yeah,
right?
but Jack, by the
Yeah.
same token, we know that the lesion. I mean, this issue around PSA is for people who don't have lesions. Like you thought you never had a lesion, and so we had to get your
Right.
PSA to a level, right? But if we know
Right.
you have a lesion, then that lesion is going to show up. I mean, we know where to look. We know where the lesion is. If the lesion doesn't show up now, it means it's not there now. It's not a function of your PSA anymore. It's a function of all those prostate cells that were gathered together making the lesion.
Yeah, but
So
Rick,
I'm
show
not
up
so
with what kind of a scan?
PSMA scan. If a PSMA scan that showed the lesion doesn't show the lesion now, it would suggest to me it's not there. Not irrespective of your PSA level.
Well, that seems a little counterintuitive. I was talking about that with somebody. The Sloan Kettering approach is you shouldn't have gotten the SBRT, he told me. You should have just gone with the doublet therapy, and we could have shrunk everything down to being non-visible. And that was his approach up in Sloan Kettering. Down here, California, Peter Carroll said, let's go with the SBRT. Guy down here said, let's go with the SBRT. I went with the SBRT, and I hit all the oligometastatic lesions, and that plus the doublet therapy. So if the rationale of Sloan Kettering is we can shrink it down to nothing, how are you going to see something that can be shrunk down to nothing?
Well, but isn't that the point? I mean, you're asking, are the lesions still there, right?
I'm
Isn't that
asking,
what you're asking? I mean, has the spot
I'm asking,
radiation been
I'm asking if
successful?
the SBRT was effective.
Well, do you care whether it was the SBRT that was effective or the hormone therapy that was effective? What difference does it make?
I'm concerned that the SBRT was worth doing or not.
Well, but we don't know. You just chose to do both. If you were that concerned, you could have chosen to do one and seen whether it worked. And if it didn't work, you could have done the other. But the fact is you chose to do both. And as you know, in any type of trial, if you can't isolate, you don't know what was responsible for it. So
True.
what I would do is I'd get another PSMA scan, and I knew all the lesions were there. And if they're not there now, then the treatment has been successful. Whether we attribute it to the hormone therapy or we attribute it to the spot radiation, we don't know. Now,
Well,
God forbid something comes up again, then we have to decide, well, you want to do both, you want to do one, you want to do the other. But hopefully we don't have that opportunity to decide. I mean, that's how I would look at it. Anyone else?
Yeah, I agree 100%.
I've had so many scans. I've had 2 PSMA maximum scans over the past 2 years. And, for me to go and hit myself with another scan when my white count is hovering 2,400, 2,800, to me, it just seems a little bit too risky. And I would just as soon find another way of determining whether or not this worked, short of having a PSMA scan.
Yeah,
I
but there
guess
is no.
you
Go
could get
ahead.
an MRI scan, but it'll be non-specific. I don't think an MRI
That
could
I
tell.
would prefer that. And what are the chances of something being visible or diagnostic when you have an MRI scan of the.
Well, it won't be done. Well, the MRI probably wouldn't be able to tell a metabolically active lesion from a sclerotic one. Am I right about that? So
You mean the
therefore, you
FDG
won't. No, the
or
MRI.
MRI? Don't
So
they do
there,
MRI, FDG MRIs?
yes, yeah, I think they do.
I heard about that. Yeah.
Yeah, MRI guided FDG scan. I think I've heard about that.
And then you could determine hypermetabolic disease with FDG, and if you do an MRI, that would be sort of a more innocuous way of doing it, even though you're going to get some uh, effect from the FDG.
I guess
I think
it's worth asking.
they usually use CT, but
Yeah,
MRI is better, but it's more expensive. Joel, did you have a comment?
I did, but Rick covered the subject very well about PSMA and PSA, so I don't have anything else.
Yeah, okay.
let's say the lesion is pretty much gone or just a shadow now, which is probably what we all expect. We we sort of want the cause of that to be the radiation rather than the ADT, don't we? Because radiation has the capacity of, well, Jack's shaking his head, so he gets my point.
I agree.
Yeah. So, but since there's two interventions, there's absolutely no way to tell.
Right, right. One more question. How do you distinguish between metastatic symptoms post-radiation versus side effects from radiation? In other words, I have feel discomfort in my rib area and in my lower back, and how do you separate that from Peter? Can't do it.
What's an age-old question? What's going on with me? What's bothering me? Is this the cancer or is this the side effects? It's a pretty
Yeah,
difficult determination. I don't know any definitive way to do it. It goes round and round in our heads, that's for sure.
yeah. That's I guess that's why it's so confusing to me. Well, those are my two main questions. And one more is I started going on metformin, 250 BI twice a day, and I did it because my fasting blood sugar for the first time, usually 80, 85, it went up to 99, 105, 107, three different times. So I became concerned, not wanting to stress out my pancreas. So I started on 250 twice a day. It's not the normal dose of metformin, but from what I've read, metformin's a fairly good life extending drug anyway. Anybody taking metformin and finding it valuable?
This is John. Metformin took my A1C from the low sixes down to the 5.7 range post haste with no side effects at only 500 milligrams a day.
Okay, did you split it 250 twice a day or 500 once a day?
Once a day at bedtime.
Okay. Thank you, John.
Great drug, I think. Cheap as anything.
That's
My
true.
primary care started it because I developed ADT induced, glucose intolerance. But when my
Yes.
oncologist heard that I was on it, he said, "Good, I like that."
Yeah. Good.
I took it for years, for about 7 years, prescribed by my medical oncologist, one of them. But I stopped about 9 months ago or so because something controversial came out in the news about it, and I decided I'd stop it.
I saw something within the last 6 months too about metformin not being what we hoped it was.
Right.
There is something there, yeah.
We very mixed things about it.
Yeah.
Yeah, well, everything I've read says that it's helpful for prostate cancer patients who are diabetics, but otherwise not.
Right.
Oh, really? Well,
Um,
it's helpful. It's helpful for everybody according to some literature. It's like one of those things everybody should be taking, like low dose Lipitor, low dose metformin,
I was
low
going to
dose
say like a
lithium.
statin. Yeah.
well, when I say helpful, I mean for prostate cancer outcomes.
Okay.
Uh, okay, so Dr. John, you're up next.
Thank you.
Rick is going to love this one because it proves him right about something. But I just got a PSA back today, which was non-detectable. This is after my PSA went from non-detectable and jumped up to 0.01. So should I panic when it goes up to 0.01 after being non-detectable and think, oh my God, my cancer's coming back? Or should I have not gotten such a sensitive test in the first place so I wouldn't have to worry? So it's back down to non-detectable. How do you like that, Rick?
First of all,
I
let's
hope
not
you
use the term jump when you go from undetectable to 0.01.
Jump is when you put the emotional spin on it.
Yeah.
And it certainly isn't a jump. It's just barely inching across the line.
John, I hope you're
Yeah,
putting us on.
What?
well, go ahead, Rick. I'm probably on the same line of thought as you, so
Better
Let's
get
go ahead.
3 digits.
Yeah, that's right. Let's look. Yeah.
So hold on a minute. First of all, Dr. Jack had something to say. What did you say
I
to
said,
John?
John, I hope you're putting us on.
Um,
I had to go on Valium. No, I didn't really.
if it were me, I would probably test again in a month, 6 weeks, and if I really didn't want to get anxious, I'd go to the old-fashioned 1 decimal place and wait until it gets above there. But the bottom line, and I did get a couple of responses to what I wrote. And the best response that I got was from somebody we've been working with for many years. He doesn't come on the groups, and I won't use names, but he said he's very happy because he's delighted he gets 3 digits because he's at 0.008 and it's been like that for about 2 years. And I wrote back and I said, well, you're just the sort of guy that I had in mind, because God forbid it went from 0.008 to 0.012, you'd be beside yourself. And he wrote back, he said, yes, I am very anxious. So I said, well, why don't you do yourself a favor right now and move it? Because what are you going to do? Even if it is going up, we're not going to act on it really until it gets somewhere around at least the 0.1 level.
Probably
So,
0.2 even.
there's that piece that we talked about last week from Peter Carroll and D'Amico, which is maybe you should be doing PSMA scans earlier, because if we can pick it up at less than 0.2, it's good. But somewhere in that 0.1, 0.2 range is where it's actionable. Below that, it's not even actionable. So what's it doing? It's playing with your head. And if you can handle it, God bless you. But if you can't handle it, then change what you read it to, and only you can decide that. Len, what were you thinking?
No, exactly what you're saying, Rick. You and I are on the same page, always have been on this. What's the point in knowing that you went from undetectable to 0.01 when you're not going to do anything about it? You're not going to take chemo. It's going to kill more healthy dividing cells like your hair and your mucosa than it is cancer cells. Uh, I, I just don't see the point. If
And
it's
if
not
you're on,
imaginable, don't do it.
yeah, I mean, if you're on a holiday, if you're on intermittent, you should already have a an arrangement with your doc as to when you're going to go back on again, and it ain't going to be at 0.02. That's that's for sure, right, Len? I mean, you're the intermittent king here.
Yeah. I'm at last count 0.15. I'm relaxed. I'm not taking any tranquilizers or I'm not worried about it. But everybody's different. I understand that. But the point is, what are you going to do with the information you have? Like Rick said, if you can't take any action on the information, it's useless, in my opinion, except to give you anxiety.
Yep.
I mean,
All
we've
right,
got a
John,
lot of guys. We've got
you
a
far
lot of guys
surpassed
in
your
this
10
room.
seconds.
We've got
No,
a
no,
lot of guys.
it's you guys talking. That doesn't count against me.
We've got a lot of guys in this room, and most of you are dealing with this issue because most of you, I think, are still monitoring your PSA, probably more often than once a year, which very few of us are now fortunate enough to do. Do you have opinions? What do you think?
Peter, you're muted. Peter Kafka.
I think it's a really valuable test, particularly for some of the guys on the call this evening who are seeing literal jumps. And if you know that things are on the move and you wish it was something different, I mean, that's where we should be talking about. These minuscule things are, to me, insignificant. Even my own are insignificant. But there are people that have, real concerns about this kind of stuff, as we'll probably get into as we go along this evening. So I think that's where our attention should be.
I mean, knowledge is valuable, so it's always, it's not bad information. It's information. If you can set the other part aside, the anxiety around it. I mean, that's easier said than done, but I'd rather know than not know.
It's actually, in a way, Jeff, you could almost argue that it's not information. You could argue that it's noise.
Yeah. Somebody had their hand up, I believe.
I think it was
Gary,
Gary.
Gary.
I had a question for you, Len. You said you're at 0.15.
Yep.
At what point would you want to intervene?
Well, my doctor says 0.2. A lot of oncologists are now pulling the trigger on the PSMA PET scans at 0.2.
Right.
Which used to be higher than that. They used to be 0.5, 0.6, but now
Right.
they're doing it at 0.2. So I guess
Yeah.
I'll do it when he wants to do it.
I think that D'Amico Carroll paper from 2 or 3 months ago has become pretty seminal. I think it's a really, really important paper. It certainly changed my mind. I mean, maybe also because I have so much respect for the authors, and it's not worth, for the sake of a scan, it's not worth waiting because we may find something. If we don't, then we just scan again. That's the worst. That's the worst thing.
Right.
A lot of it depends on where you are in the journey. I mean, if you've already done chemo and if you've already done this or that, I mean, sometimes you can wait longer, sometimes you can wait less. It depends on what's in the future for you, what kind of action you might be taking.
Yep.
Okay, can we move on to Dr. Jeff now? Jeff Gilbert.
Yeah, so I have a couple of questions I'd love input on. So I had fiducial markers put in last week, and I had a simulation session today with a CAT scan and tattoos, etc. After the session, I had a meeting with the medical people, and they recommended that I start a product called Isorel, which is a soy isoflavones supplement, 200 milligrams a day for until the radiation is finished, which will be in about 3 months. Uh, any any feedback on anybody who used these soy isoflavones during the radiation to reduce? Papers have been written talking about reduction of urinary symptoms, bowel symptoms, things like that.
That's new to me. Anybody know anything about this?
I sent Rick, that's the article I sent you
Yep.
today. But there are a
Yeah.
number of articles. I bought it. I'm waiting for it to come. They gave me samples for 10 days. One thing I can say though is, and I brought this up last time, I asked the question whether using tofu, eating tofu every day would reduce hot flashes, flushes, that uncomfortable feeling. I've been taking it now 2 times a day, and my hot flashes have definitely decreased. I was getting them 5, 6 times a day. In the last uh, 3 or 4 days, I've had one, sometimes none. So there may be some value, and I know I asked this question, but I guinea pig myself, and there may be some value to eating tofu, which is a soy product, which I'm sure has a lot of these isoflavones in them, Genistin and others, to reduce these lousy feelings that we get like we're in menopause. Um,
I had read some articles about soy isoflavones for hot flash reduction, and I have been taking them for a few months, and it might have helped a little bit, but not a lot.
the capsules you're referring to,
Right.
not eating the tofu.
Right.
Okay.
I've just looked, this is John, I've just looked up this Isorel. I had never heard of it, and I don't see any articles on using it as to assist with radiation therapy, but I do see articles about using it in colorectal cancer and in vitro. Um, it seems to have effect against some other cancers as well.
There are
So,
articles mainly for menopausal women
Hmm.
right.
saying that it has some effect for hot flashes.
So, guys, if you click on the link, it's the one that Dr. Jeff sent me earlier today. It is specifically about radiation therapy in patients with prostate cancer, soy isoflavones in conjunction with radiation therapy in patients with prostate cancer. So that's a reference, a citation that is on the money. We would expect no less from Dr. Jeff. So thank you. The one thing that I picked up, which I thought was really interesting, and I just read the abstract, I didn't read the whole article, was that the mechanism of action is to stimulate antioxidants. And I found that kind of interesting because we have heard that you should stop taking antioxidants during radiation because antioxidants interfere with radiation. And so if you're on a supplement that creates antioxidants, they say don't take it during radiation. Also, and this is my bad, and I'm going to change it in the next reminder. I know the link that I posted to the antioxidants article in the reminder was bad. I've put the proper link in here. But there's this other article that we have that says, well, antioxidants stimulate blood cell growth in tumors. So we got both sides of the coins. We got both sides of the coin here, and I don't know which is right and which is wrong. I think that maybe the Brains Trust can give us an opinion on the article that Dr. Jeff posted. I do see that one of the this must have been done at the hospital in Detroit, Carmanos, because one of the authors is Elizabeth Heath,
Wayne State.
Wayne State, Carmanos, right? And so Elizabeth Heath is one, and Dr. Vaishampian is one who she's now over at Michigan. She's now over at the University of Michigan. She used to get rave reviews from the people that saw her. And we think Elizabeth Heath is very, very good. So, we got people we can follow up with, but this is a puzzler for everybody to think about. And I guess if it's working, Dr. Jeff, stick with it. I don't know what to say to you. You're not worried about the antioxidants?
But what's working is the effect on hot flashes and
yeah.
Whether this has any effect. Their recommendation to me was it'll decrease side effects of the radiation in terms of urinary issues and such. So I won't know that. I mean, I probably never know it because I'll take the radiation treatments, but I don't have a baseline. I'm not a double-blind study.
Right. Now, it's interesting that they say that it'll reduce the effects it'll help with the side effects, because in fact that's why they say to us, don't take antioxidants during radiation, because it reduces the impact of the radiation. So these guys are saying, well, take the side effects because it'll reduce the impact of the radiation in the places you don't want it. I mean, essentially, that's what they're saying, the same thing. I mean, anybody here has any input on antioxidants during radiation? Has anybody ever discussed that with their radiation oncologists? Supplements during radiation? Anyone discuss that? Well, we've definitely been heard, and there are docs that tell you stop taking your supplements during radiation.
Well, the quote they gave me is this. I'll very, very brief. A recent study showed soy isoflavones may lessen the side effects of radiation for prostate cancer. Men who took 200 milligrams of soy isoflavones during radiation had fewer urinary symptoms, better sexual function, and fewer GI symptoms than men who took a placebo pills. In addition, PSA levels decreased more in the men taking the soy product.
Right.
I don't know if it works or not. I'm asking.
How big was the population size, Jeff?
It seemed fairly high in the article I sent, but that's one article. I've read a few others too, where they had a significant number of men who took it and didn't take it. I just thought somebody here might have had experience with it.
It wasn't a big study, the one that I posted. It was 42 patients, of which 26 or 27 returned the completed questionnaires. But I just encourage you all to take a look. Take a look at the study, especially my Brains Trust guys. Take a look at that study, and we can talk about it again. But it's really interesting. I mean, it's two sides of the coin.
Well, if I was in Jeff's place, this is John, I had a lot of diarrhea during my radiation therapy, and often it was very rapid onset. and caused me a lot of distress. So if they gave me a chance to do that, I'd do it.
I bought it and I started it, so we'll see.
Good. Let us know.
Okay.
Nice one.
I have one other quick question. Anybody here who underwent radiation therapy, anybody had a resume procedure, let's say 6 months before the radiation? Because I had a resume done for obviously BPH while I had cancer and they missed it, but uh, one of the people said to me, "Oh, that's fortunate that you did have the resume. You'll have less issues, less urinary issues with your radiation." Anybody know anything about that?
Nope.
Never heard of it.
I never heard of it either. What does it involve, Jeff?
Oh, the resume? Well, I
Yeah.
had BPH, so they said we could do Urolift, or we could do the resume. Resume is superheated water, steam,
Steam.
introduced into the prostate to kill the prostate cells, to reduce the size of the prostate from BPH.
So the
Oh.
person I would ask about that who might have some insight would be Steve Kaplan at Mount Sinai. Do you know Steve Kaplan, Jeff?
I know somebody who could get me to talk to him, yes.
Well, I'll tell you what, I'll give you his email and just tell him that you're now with the AnCan group and send the email directly, especially since you're a doc. And he's a good guy. He did a webinar for us on BPH last year, a really interesting webinar on BPH. And he's been very nice about getting back to us when we've had questions or asked for referrals or what have you. So give me a moment and I'll send you I'll send you a couple of emails
Thank
that you
you.
can reach him out and ask him whether he has any opinion on Resume and how it might affect radiation, because he's a very smart guy and he is really the guru on BPH.
Thank you.
Now, I have a question for you. What type of radiation are you moving forward with?
So it's an external beam of 48 sessions. Each session will be 15 minutes, I'm told, and should be over by December 8th or so. But I'll be going every day, every weekday, for 15 minutes of treatment.
And you don't want to reduce the treatment to the gland yourself, the gland part of it, by say 24 treatments down to 3 or 4 or 5?
So I had this discussion, and I had it actually with people from Sloan Kettering, and one of the things they tell you when they do this truncated therapy down from 40 some odd is, oh, very small risk, but it happens, of bladder cancer. And I had two friends who I sent to Sloan before I ever had cancer, and both of them opted for this. Both of them were Gleason 9s, like myself, and they both opted for this shorter treatment, 10 treatments or so, 5 over 10 days, something like that. Both of them got bladder cancer within a year. Both were told, well, it could be 5 years, but it's too coincidental for me. And so I'm going to go with the 48 treatments.
Okay. I mean,
How many
the other,
How many gray is that, Jeff? Did they tell you?
Well, I don't say it in.
How many gray, the radiation measurement?
I'll have to ask she wasn't there. The radiation oncologist wasn't there today. So I'll see her on the 2nd, I think. I'll ask her on the 2nd and I'll give you that answer.
is that Kohlmeyer you're seeing?
No.
Dr. Kohlmeyer?
No.
Okay. because she's really good. I mean, that's somebody that we like a lot, Dr. Kohlmeyer. She's treated a bunch of our guys. I mean, the other alternative is to do like I did was brachy, either HDR or the seeds. And
Well,
I've
they
never
told
seen.
me seeds weren't for me because I had spread to the seminal vesicles.
Yeah, but they can cover the seminal vesicles with the IMRT, and the treatment of the gland itself is with either seeds or HDR, high dose brachy, which is what I think that's what Joe got. Joe, you did the high dose brachy and the IMRT, didn't you?
Yes, I did. I had HDR, and HDR will allow them to actually cover more of the gland uh, because of the fact that it's directed. They use basically catheters and place it either right on or right next to any of the areas that they're planning to treat. And the HDR is a short-term procedure. It's an in and out same day.
Yeah. I mean,
But
that they say. Go ahead, Joe.
I was just going to say I had a comment out about Rezum, although I haven't had it, but I know a bit about it. Rezum is a steam procedure that goes along the urethra to basically kill off a small length or segment of the prostate. So it just basically opens things up, and it's it shouldn't have, from where I can see, it shouldn't have any impact on radiation at all.
But I have heard, Jeff, that if you reduce the size of the prostate, of course, you'll have an easier time targeting the prostate with
Yeah.
radiation. And of course, hormone therapy will shrink your prostate. Are you getting any hormone therapy?
Yeah, I'm on Firmagon once a month and abiraterone every day.
Yeah, so that should be shrinking your prostate. Maybe you don't really need the Rezum.
No, I had it already. I mean,
Oh,
I
you
had
already
it.
had it.
Yeah, I had
Okay.
it back in March
Right.
when I was having all kinds of BPH symptoms. But as I mentioned, I think I mentioned, that I was complaining of symptoms. I was asking for things, simple things like a rectal exam and an MRI, and I was kept being told, you don't have cancer, you don't have cancer, you don't have cancer. And I had a Gleason 9 when I got the second MRI. And uh, so I guess this provider is trying to make me feel better for why I underwent the Rezum when I have cancer by telling me, well, you'll have less symptoms from the radiation because you had the Rezum. True or not, there's no way for me to ever know.
It's the Rezum is basically as if they came in and took to just shave off a small row of cells on either side of the urethra. It's opening it up.
Right. They superheat your prostate
Right.
and
Yep.
kill your cells, but
Guys, before we go down the Rezum rabbit hole, I want to come back to this choice of treatment because I think it's an important issue. If there's a gold standard, then we seem to think that it is brachytherapy plus IMRT plus hormone therapy. And if you go to Alan Edell's blog, which I just put the link in there in the chat window, you can click on that link, it'll open. You don't have to copy it, just click on it, it'll open, you can look at it later. And if you search, I think even for brachytherapy, it'll come up this that now probably that is the best treatment. I mean, that's the treatment I got 15 years ago, and it's still considered to be a good option. The brachytherapy can be low dose, it can be high dose. Now, Since then, we've innovated the use of SBRT to treat the gland. So another option is treating the gland with SBRT plus IMRT. Not 4 or 5 sessions as you were told, Jeff, but what Mac Roach does now at UCSF is he only does 2 sessions of SBRT, and he follows that with 24 or 25 sessions of IMRT. And that's what he feels works, and it's necessary. Now, I've not heard about risks of bladder cancer with SBRT. That doesn't mean a lot because there's a lot of stuff I don't hear about. But that's not on our radar. Anecdotally, I don't take anything away from you if you have. But I do think that, you know, and the man to talk to for you is Zelinsky, because he was the breaky guy at NSKCC. Zalewski. He was the breaky guy, and he's going to talk to you candidly, and you know, especially since you know him. But I mean, to me, I just don't see the sense in this day and age of having to go through 48 sessions when you can do it in 25 sessions.
Julian's been trying to make a comment for that.
Yeah, go ahead, Julian, please.
I had a Gleason score of 9, okay? And before I started my radiation treatment, so you know my full story, I don't give you piecemeal, is I had actually a space OAR inserted between my prostate and my colon. And then when I was talking to these guys, they said, well, try HDR brachytherapy boost. And that was a 1-day procedure because they were going to give me 39 treatments of radiation. That 39 went down to 23, and it made a big difference. I'm still here. I had a colonoscopy a couple of weeks ago. They didn't find anything wrong, so that's my story.
Not that it should influence anything, but the compensation is based on the number of treatments you get. So depending on who is interested, that also can influence it. That's why a lot of places are still doing the 40 something. I just had what the same as you did. I had the 23 external beam IMRT with 1 dose of high dose brachy.
Mine was actually called VMAT, which is a version of IMRT.
All right. Well, what I've heard is that Rick is right. The combination of IMRT and some form of brachy is most effective, but it also has a higher incidence of urinary toxicity. So you kind of have to weigh those two things. But you're going to Sloan Kettering, right, Jeff? That's where I went too. And I got the same treatment there lining up for you, 48 treatments. They're doing your whole pelvic region along with your prostate, right?
Yes.
Yep. That's what Sloan Kettering does. That's their MO.
Yeah, I mean, look, there's no argument on the pelvic girdle. We all agree on that. The issue is, how do we treat the prostate gland, the gland itself, not what's outside the gland, but the gland itself. And that's where I think we're saying there's enough really solid docs who will do it with brachy or SBRT today, and that's where you save the time, because it's the 20-odd sessions, 20 to 25, it depends. It's those sessions that we can squeeze down to 1 session, and definitely brachy plus IMRT plus hormone therapy has been shown to be more effective than IMRT plus hormone therapy. And that research you'll find on in Alan Adele's blog if you look around in there. There's a lot of stuff in there. It's good stuff. he writes it in, he's usually pretty accurate. He writes it in his own verbiage. He gives all of the citations, but I really encourage you to do that. And the other thing I encourage you to do is to talk to Michael Zalewski, because he understands this stuff real well. Before you start, and before they start radiating your gland. Listen, if they want to radiate the pelvic girdle first, that's fine. That happens a lot of times. And then that's what they did with me. They radiated my pelvic girdle first, and then I had the seeds installed afterwards. But don't let them radiate the prostate gland first, because that'll give you an extra month or more to do your research. So tell them you want them to start with the pelvic girdle.
I think that was her plan. Yeah.
Yeah, I
But
think that's the way to
I
do it.
don't like, I don't personally, I don't like seeing somebody go through 48. They don't need to, and it's not the best treatment. And whether there's a financial issue in here, and I don't know. I don't want to say that, but it ain't the best treatment. That I think we can pretty safely say from experience and from having read the clinical trials.
All right, we need to keep going forward. Jay Newman, you're up.
Just a quick update. I was on enzalutamide for 7 months, and I was experiencing severe dizziness. So I got switched to darolutamide, and I've been on it like 4 days so far. I think I'm still experiencing dizziness from the enzalutamide, but hopefully the side effects will be lessened and the dizziness. So that's basically the update.
So tell us about that process, because when we spoke to you last, you were going to ask for the darolutamide. Was it easy enough for you to do that?
Yeah, it was easy to ask. The doctor said, I think he was kind of surprised that I was so knowledgeable about the darolutamide and the fact that it didn't cross the blood-brain barrier. But he said that it's not really approved for my case. And we said, well, why don't you just write it up that I've tried the other one for 7 months, and I was not having a quality of life, and that we wanted to try something else. So my health insurance picked it up, and I'm receiving funding for the cost of the copay, and everything clicked into it, and my copay is $10. So
Fantastic.
they're very pleased, and you guys are fantastic and offering a lot of information and advice and questions to ask the doctor. So I do appreciate you guys very much.
Thank you. We
Yeah,
love it.
so Jay, I think you'll begin to feel better in the next couple of weeks, probably. Got to give that enzalutamide, kind of beat you up a bit. It'll take a little while for you to recover. I think you'll find darolutamide's a much easier drug to be on.
That's what I'm hoping.
Patient. Yeah. Okay. Gary Peters, you're up.
Can we just check if anybody has any questions on that, because this comes up such a lot, and I know that some of you have had trouble with your docs and they don't want to apply. I mean, anybody got any questions for Jay? I mean, he could be our expert here on getting darolutamide. Anybody want to ask any questions on this one?
I know Bayer's still running a free trial with it. So you go to your doctor on that basis. You could probably get a couple months and try it and then jump onto it. That's what I did.
So just as an aside, we're in the midst of a discussion with Bear right now.
I got water.
You sure? Want a glass?
Bear
Thank you.
is one of our funders, as you hear all the time, and they're a generous funder, and they told us they're going to be even more generous next year, which is great, except that they snuck something into their arrangement that we cannot live with, which is they want us to be obligated to report adverse events for their drugs, namely for darolutamide and Xofigo. And we say we can't be held responsible for that. We can tell our guys, if you've got issues, you're supposed to report them, adverse events, you've got to report them. But we as moderators can't be attending all our events and reporting adverse events. So, you know, if Jay comes back in 3 weeks and he says, oh, I'm still feeling dizzy, and we're supposed to tell him. And we may say, well, it's not the, you know, in fact, if I'd signed the agreement, I would have to tell him right now, you've been on darolutamide for 4 days and you still feel dizzy. That's what it says on the paper. So we're being asked to make a judgment on these adverse events, which is ridiculous. And I don't think any other support group is having to do that. I don't think that Zero has to do that if adverse events get reported on the Inspire forum. And we've told them, you know what, we'll just forego the funding. You know, it's 25 grand. It's a lot of money, especially for us, but we're not going to do it. And they don't get it. So I don't know where we're going to go. Watch this space. It's a bit of a difficult issue. But we cannot be running support groups where we are reporting adverse events. I mean, that, as most of you know, if you are taking a drug and you have an issue that's associated with that drug, technically you're supposed to report it. Most people don't. But, you know, is there anybody on here who's ever reported an adverse event? Oh, Pete. Oh, yeah. Well, that was the rash. That was your rash. But we found out that was the PPI that was related to the PPI, right?
We didn't know, yeah, but we didn't know that for a year afterwards.
No.
I knew it was related to the Orgovix. I mean, that was
right.
I knew I started that and immediately got the rash.
How do you actually do it? Let's say somebody comes to us and said, I took some darolutamide and I got a stomach ache, and we said to them, please report it to Bear. Do you go to the Bear website and fill out?
Yeah, there's a
FDA,
telephone number.
FDA.
You go to FDA or go to Bear?
FDA. I went to both, but FDA first.
Yeah,
so if we got somebody in our groups, we certainly don't want to be in a position of reporting ourselves, but we could be in a position of saying the company requests you to report this yourself. Do we send them to the Bayer website or the FDA website?
Bayer wants us to send them to a email address that they've given me, and what we've offered to do is to say, look, we'll tell the guys in the reminders and we'll put it on the recordings. If you've got an adverse event, you're supposed to report it. The problem is we're not going to do it just for Bayer. We're not going to single out Bayer. What about Janssen? What about Pfizer? What about all the other many? What about Myovant, as they're now called? You know, so it's a very slippery slope. But the fact is, you can report to the FDA, or you can go to the website of that drug, and it's very easy to find how to report it. The issue when you report it is that it's not simple. There's all these questionnaires, and then they come back and they ask you, and it takes time. So, and So you got to be prepared. You got to be prepared to answer all the questions. It's not a bad system, but certainly for us as facilitators of support groups, and we're peers as well to boot, we can't do it. If we were professionals, maybe we wouldn't have the excuse. But anyway, that's Jay's a fantastic example. After 4 days, he's still feeling some of the side effects. Well, it's from the old drugs, but technically, got to report it. If we signed the agreement, which we ain't gonna do. So,
Back
all
to
right,
Gary.
sorry.
Go ahead, Gary.
So, a few months ago, I got off abiraterone after over 2 years daily abiraterone and 5 milligrams prednisone. As I was weaning off the prednisone and trying to go slowly, I hit a real cliff in terms of fatigue and became more tired than I had been up until that. And we had just on this forum, there had just been talk about cortisol and ACTH tests. I think Dr. Jack may have mentioned it, but I went to my endocrinologist and I said, I'm dragging like never before. Can you test my cortisol? Which she did. It was well below normal. And I'm now on hydrocortisone for 8 weeks in the hope that my body will start to produce what it should be producing from the adrenals. My question is, has anybody else experienced this, or have the docs experienced this from supervising it? And is this likely to come back so that I don't have to be on a steroid forever?
So it's it's not uncommon for people who've been on steroids, prednisone or other steroids, to suppress their ACTH and interrupt the feedback between the adrenals and the pituitary hypothalamic axis. And if you're not making ACTH, you're not going to make cortisone and you're not going to make mineralocorticoids. So they may have to put you, as you said, they put you back on a steroid, but they can taper it over an extended period of time, smaller doses, in hopes of giving your hypothalamus and pituitary time to start reproducing the ACTH. And it's often successful.
Okay.
Gary, what was when you weaned off of the ped, what was your program?
I took like 2 months. I was going like from 5 to alternating 4 and 5, and then 4, and then alternating 3 and 4, and then 3, and then alternating 2 and 3, and then 2. When I got to 2, that's when I really fell off the cliff. And I was just exhausted from 2 and on down. And I was still taking 1 milligram when I tested too low for cortisol. I don't have the numbers in front of me, but I thought I recollected that ACTH was normal, but cortisol was well below normal.
Well, if you have normal ACTH with a low cortisone, you should have an elevated ACTH level. But if your ACTH was normal, the issue may be in the adrenals,
I
not in
think
your
that's what
not in your
that's,
brain.
that's where it was. Are
I'm
those
so glad
likely?
that I'm
Are
really
those like?
glad that Gary got this blood test done. We've had a number of people that have had difficulties with tapers over the last couple of years, and we have speculated that the tapers, even though they're commonly prescribed, like I went from 5 to 2.5 for 2 weeks and then off, and everything was fine. And I think that's kind of typical of what the doctors recommend. We don't normally recommend tapers of several months from only 5 milligrams of prednisone. This
That's
is the
what
first time.
my oncologist recommended what you just said, John.
Yeah, and I think that's typical. But this is the first time we've had laboratory evidence about it. So I'm really glad that you went to the endocrinologist and got that blood test. And like Jeff is hinting at, we want to certainly make sure that you don't coincidentally have Addison's disease while we are tapering off, and your adrenals just fail to wake up.
Right.
Addison's disease is kind of difficult, and it often takes forever to diagnose. And so I think it's just great that you got that blood test and consultation at this particular time.
Are you still taking the abiraterone?
No, just hydrocortisone. But she suggested the problem was in the adrenals, not
Right.
the brain.
Right.
Are
Jeff
those likely to come?
Jeff Mochi, go ahead.
Yeah, well, I stopped prednisone and Zytiga 2 months ago, and I went to half a pill for a couple of weeks. And in the afternoon, for about a month and a half, I was really tired, really had to sleep, and it's gone. It took me a couple of months, and my doctor did say that after we had talked about it, she did say I could go back on a smaller dosage of prednisone, but it did. Things went back to normal. I'm 75, so it's probably age related too, but it did go away without having to go back on prednisone. Just it can happen. So keep your spirits up.
So when you suppress the adrenals for a lengthy period of time, as happens with when you take abiraterone, and I'm sure there must be other drugs that probably do that. Can they be very lazy in coming back? I mean, we know with the gonads that it happens because some guys recover their testosterone quickly, other guys take a heck of a long time to recover their testosterone. So medically, we got three docs on today. What can you enlighten us on that?
I think the question always should be asked, what was the state of the adrenals beforehand? Before the abiraterone, before the prednisone? Because there are patients who have a degree of adrenal insufficiency to start with, age-related, stress-related, and then we go on these medications that block hormone synthesis and push them over the edge. And then we stop the prednisone. I mean, you get prednisone to prevent the insufficiency, and then you stop it, but the adrenals have been beaten up over time. And, we don't know where it started, what the level was before all these medications. And so some people, their adrenals pop back over time, and some people it takes an inordinate amount of time. And there must be people who need replacement therapy forever.
Yeah.
Without
Here's a
the
question. Here's a question that we've never really contemplated before, but gets raised. I mean, we routinely tell gents who are starting hormone therapy to get a baseline level for their testosterone. We do that. There are still medical oncologists who don't believe it's necessary. We just disagree with them. We're not medics, but we think it's really, really important because it helps when you come off. Do you think that for men who are starting abiraterone, we should be telling them to get baseline levels of cortisol and ACTH?
It's a simple blood test.
Okay.
And I think if you were going to do it, I think you'd have to do multiple bloods, though, because, the highest ACTH level is 8 o'clock in the morning. The lowest is in the evening. So you'd want to know where you are at different points in the day to get a baseline.
So when you are testing somebody for ACTH and cortisol, is that what you do? You'll tell them to come in, get something early in the morning and get something late at night?
Right. 3 times. Usually it's spread out 3 times.
Okay.
Well,
That's great.
The reason they give us the recommendation to take prednisone at 8 o'clock in the morning is because that's when we have our highest ACTH levels. So you're less likely to suppress that axis if you take it at 8. So were you taking your meds 8 o'clock a.m.? The prednisone?
Yes, first thing.
You were.
Yeah. Without the replacement therapy that I'm taking right now, would I be in a situation of Addison's disease?
You might. And Addison's is serious, so you don't want to get there.
Okay. Thank you.
Now, John Kennedy had Addison's disease. He took steroids his whole life. That's why he had such a round face, and he looked so healthy.
It wasn't Marilyn Monroe? I don't know. I'd look healthy and have a round face if I had Marilyn Monroe in my back pocket, I'll tell you.
If she'd come to my birthday party, I would not mind taking the supplementation.
Oh boy.
Well, it's kudos to you, Gary, for going for
just
seeing
saying
an endocrinologist in the first place.
Yeah, it's good.
I'm sorry, did I interrupt somebody?
It's good that we're all a bunch of old farts, so we get the jokes around Marilyn Monroe. If we had some young people in there, they wouldn't know what the hell we were talking about. Yeah, Len was saying it's great that you took the initiative to see an endocrinologist. So that's great. I mean, I'm really pleased that at least we found out what it is, and now we just got to monitor it, and hopefully you're going to be a situation where at some point it will wake up and let it's now on our radar for guys starting abiraterone that maybe they need to get a baseline for their ACTH and their cortisol. And it'll be interesting when they go back to their GU medonc and they ask them, see what the GU medoncs say. I mean, Dr. E would say fine, yes, definitely. But I can see a bunch of them, we getting a bunch of pushback from a lot of our GU medoncs when our guys go in and say, hey, we need to get our ACTH and cortisol tested. But we're going to use Gary Peters as our example, as our
It should be very, very rare to find somebody by doing that. That may be partly why routine screening is not done. But who knows? Maybe it's a little more common than we know. And that's why we hear about it so much when guys taper off in this group.
I mean, my go-to story on this is a friend of mine who we lost to prostate cancer eventually, who was on abiraterone in the early days. His doc was the doc who actually discovered it, and his office forgot to tell him to taper, and literally forgot to tell him to taper. And he stopped his abiraterone, he stopped his prednisone, and for 90 to 120 days or more, he was getting sicker and sicker and losing weight and feeling terrible and this, that, and the other. Couldn't figure out what the hell was going on. And eventually we stumbled across it, that he should have tapered off of his prednisone. Right. So, we've seen before. Anyway, go ahead, Len. I know you got more people.
Yeah, I do. Dr. Bob, you're up.
Okay. So just real quick background. I diagnosed April 2022, high volume de novo metastatic ADT, 6 rounds chemo, got me from 28.2 PSA to 0.48 in January, and then things have been increasing since. And when I hit 2.0 in early June, my docs felt I was castrate resistant. I have all the markers for Keytruda, high MSI, high tumor mutational burden, mismatch repair deficit. So I also got a PSMA in June, showed about a dozen mets, all in bone, nothing in soft tissue. So 12 weeks ago, I started Keytruda. I'm still on Lupron, still doing Xgeva. At the time, my PSA was 2.73. 6 weeks later, at the second infusion, it was just about 11. And today it was my third infusion and up to 32 and change. So I know Keytruda sometimes takes time. I know it's harder for T cells to penetrate into bone. So saw my doc today and we talked about some trials. They're running some bites and CAR T at Penn, but they all involve being hospitalized for several days, a week, just because of potential side effects. Talked about other issues, and I think where we may be going, though I am going to look at a trial that's at Jefferson, different hospital, same city, is Xofigo, but continue the Keytruda. Give it at least another round, if not two. I have to talk to nuclear medicine, see if they think it's something they would be willing to do, because they're both standard of care meds, but the combination of the two, I haven't found much of anyone doing that. So I'm kind of getting to the point where it's like, okay, what do I do next? And what's the least worst next option?
Well, what about falling back on Pluvicto at this point, Bob?
I talked to my doctor about Pluvicto. Her feeling was, and I've read that Pluvicto works better on soft tissue, though it does work on bone. Her feeling that was that Pluvicto would likely have more toxicity. I did run into an issue of my white count taking several months to come back after my last final chemo. It took almost 5 months for a white count to get back over 4. So that's a concern.
Yeah, but again, this is something to discuss, but I would think that Xofigo is going to have more impact on your white count than Pluvicto, because Pluvicto is targeted and Xofigo's target is calcium, so it's going to go to your bones. And so Pluvicto is a better drug than Xofigo. Now, can they be used in conjunction? Yeah, but if you're trying one for the first time, if it were me, I'd be looking at Pluvicto as long as you're PSMA avid, which you are. And I haven't heard any feedback on Pluvicto working less effectively in bone than in soft tissue at all.
Okay.
Now,
Yeah.
what I have heard is that Xofigo is no good for soft tissue, and that we do know because it doesn't. It requires calcium.
Right. Yeah. I found a study where they, and I can find it and I can try and put it in the chat, where they talked about, I mean, it's certainly effective. And I mean, I still have to have the consult with nuclear medicine. So, they may feel that one, Pluvicto is better than Xofigo, but, beyond that, I don't think she didn't think another round of chemo, Jevtana would make sense. Um, you know, and none of the trials seem great. The one that has had the best results is a dose escalation trial, but where they've seen the best results have been when they've had by far the worst side effects. And people are seeing results, but they're dropping out because the side effects are so bad.
Yeah, but I'm not sure if it were me, I'd be going to trials at this point in time. I'd be looking at a radionuclide treatment, and I
Yeah,
think
no. I'm just saying that was another thing we discussed was trials, but no, I whether it's so, I'll have the consult with nuclear medicine and see what they think between Pluvicto and Xofigo. It's
This is John. I had a guy out in City of Hope that I was following for a while. He was on them both at the same time,
yeah,
Pluvicto and Xofigo.
yep.
We
okay.
found apparently that it had been done in Australia. I don't know if it was Rick
Yep.
that tipped us off to that or whatever.
Yep.
Okay. Yeah, I mean, I can
Yep.
ask about that. I mean, I know in Australia they're combining actinium and lutetium, which are, and I know Xofigo is a alpha emitter and lutetium Pluvicto is a beta emitter.
Yeah, I think we're going to be going to alpha emitters in the future.
Yeah.
Yeah, and we can we have access to Peter Mac through Telix. We
Okay.
have access to Peter Mac through Steve Cavill, who is a younger gent in Australia who's been dealing with prostate cancer for over 10 years and regularly attends our under 60s group, and he volunteers at Peter Mac, and he knows the docs there. We've got we got Mike Hoffman. I think he knows us. We've got his email, so you can reach out to him and ask them about what's going on with those joint trials. So I think we've got some options. Just reach out to us and let us know what you'd like to do, Bob, and we can connect you.
Okay. Yeah, I'll send an email out tomorrow, and I'm not locked in into anything at this point. It's just my next step is talking to nuclear medicine, and we'll see where it goes from there. But it's a little disconcerting seeing the my doubling time being roughly 4 weeks.
Yeah, it
Yeah,
must be scary.
yeah, yeah. This is
What
we.
sort of side effects are you getting from the Keytruda, Bob?
Hasn't been bad. Just some fatigue, mostly in the first few weeks after infusion. Um, the peripheral neuropathy after chemo that got better has come back some. A little bit of reduced appetite, but nothing beyond that. So, I've been tolerating it well. It's just
at this, I've only had 2 infusions, so, I've read, 3 to 4. If you get past 4 and nothing's working, then it's probably not going to work. So, but I just don't want to wait another 12 weeks and have my PSA, go into the hundreds potentially.
Right. Peter, was your neuropathy affected at all by Keytruda, one way or the other?
Yes, still is. Yeah, went south.
Yeah.
Not terribly. I mean, I'm not incapacitated, but I feel it much more than I used to.
Yeah, I mean, for me, it's annoyance and occasional discomfort, but it's very, very tolerable. That's no big deal. So, and the only other thing, and it may have impacted my PSA, about 3 weeks ago, I got spot radiation to a particular one rib that was my worst met. That 2 weeks after the first Keytruda infusion, it felt like I had a broken rib for about a week, and then it faded. And then about 2 weeks after the second infusion, having pain in that rib again, not as bad. So they did the spot, 5 fractions about 3 weeks ago. That may have increased my PSA a little higher than it would have naturally, but the trend's still not what I would like to see. So that's about where I stand. Getting liquid biopsy from Boston Gene. I'll have those results in about 3 weeks or so. So maybe something will show up there.
Okay.
Thanks.
Thank you, Bob. We'll be very interested in following your case here.
Len?
I'm sorry, was somebody speaking?
I'm just looking something up, and on Xofigo increases the PSA in 21 out of 24 patients.
Yeah, I know Xofigo is not necessarily going to decrease the PSA.
No, it says it increases the PSA, 21 out of 24 patients.
Yeah, no, I know it. I'm not expecting it to decrease. I'm just hoping it will, keep the Mets from expanding or keep me from seeding new Mets.
Yeah.
Are you symptomatic pain-wise, Bob?
That one rib, and then here and there I'll get a little bit of pain in different spots, rib or back. I don't know if it's necessarily bone or muscle, or I'm just kind of talking myself into a side effect. Nothing severe.
Yeah. No, I'm only asking because I know Xofigo, I think, is restricted to bone symptomatic.
Yeah. Well, I mean, I had it bad enough in the worst met that I ended up with spot radiation. So certainly that allows me to qualify.
Yeah. Right. Okay. Well, we wish you the best, and we want to hear what decision you make. Is Terrell still with us?
No, he dropped off after about an hour and a half, and I'll drop him a note. He did that before.
Yeah.
If I see him, if we see him next week, Dr. John, if we see Terrell next week, we'll try and get him in early.
Okay.
I did want to come back to Gary Peters, though. Gary, are you still there? Are you still with us? I see he's silenced. Well, I was just looking at some of the strange side effects that Gary had been having, and I was going to suggest to him that some of those side effects from over the past 6 or 8 months that he raised with the endocrinologist, and see if any of those could be related to some of these other possible deficiencies. But I think we lost Gary, so I'll send him a note. Gary and Terrell. That's my homework. Okay.
All right, gents, thank you so much, and we'll see you next Tuesday.
With Dr. John.
Thank you, Len.
With
Thank
Dr.
you.
Excellent.
John, yes.
Thanks, Rick. Bye-bye.
Bye bye.
Good night.
Thank you.
Thank you.
Bye-bye.
Good night.
Good night. Good night. Goodbye.